we're gonna start with disorders of parathyroid gland. I want to start with parathyroid gland has 84 amino acids. What they do is that they raise calcium levels. Their function is basically bone reabsorption, and they will raise if calcium level will be raised. So what they do is they raise calcium levels, and calcium levels, if they are raised, always remember, then phosphate level will increase. Don't forget that. This always remember. If calcium levels are increased, then phosphate level will always decrease. And the function of parathyroid gland is bone reabsorption and increase calcium levels. Okay, then we come to another PCT. Okay, so there are more functions are there. First is the functions, I'm only talking about functions right now. So functions, the first is bone reabsorption and increase calcium levels. The second one is in proximal convoluted tubule, they help in PO4 wasting. That means the decrease levels of phosphate. Then also bone turnover, that is serum alkaline phosphatase. We call it as SAP. And so what SAP does, if if serum alkaline phosphatase levels will be increased, then automatically, so what it is made up, it is made up of osteoblast cells. Okay, so if they are increasing, osteoblast cells will also increase, and if osteoblasts are increasing, then automatically osteoclast cells will also increase. Okay, it all depends on SAP. So what is basically SAP? It is like, if SAP will increase, it is, first of all, SAP, they are found in liver, bone, placenta. In liver, it will be, it's found in obstructive jaundice. The levels of SAP are increased in liver, then it has to be obstructive jaundice, but that we'll discuss in any other video. For now, you just need to know that SAP is found in liver, bone, and placenta. Then SAP is increased in also rickets. Okay, first I told you it is in in parathyroidism it increased, and then it is increased in this rickets and osteomalacia, and PTH would also increase. And always remember, I have seen people telling that SAP is increased in, if SAP is increased, then it is hypoparathyroidism. Hypo, okay? But no. SAP, if it is decreased, it is hypophosphatasia. This is the most important point. If SAP is increased, it is hypophosphatasia. And if SAP is normal, okay, like I'm all talking about SAP, sorry, if SAP is normal, then it is hypoparathyroidism. So always remember, when it's normal, it is hypoparathyroidism. When it's decreasing, it is hypophosphatasia. It also is normal in hypoparathyroidism, osteoporosis, and multiple myeloma. Okay, multiple myeloma. And it's also the same case is also in this, like, wait, multiple myeloma. And there will be, like, like, here it's one time increasing. Can you see? Here it's one time, here I did two times. That means there will be a disproportionate rise of SAP. And when it happens in Paget's disease. What is Paget's disease? In Paget's disease, osteoclast activity increases, and if osteoclast activity increases, I told you there will be increase in osteoblast activity, and that will lead to the rise of, there will be like disproportionate rise of SAP. Then we come to the primary parathyroidism increase. What happens in this? It is parathyroid adenoma. Okay, in this, bone reabsorption, as I told you, increase of calcium levels, that will be what? Hypercalcemia. If, just imagine, there will be 11 to 12 mg percent of increase, that will happen in renal colic. Like, there will be increase of 11 to 12 mg percent of parathyroid. So what will happen? The calcium levels will be increased. Then what? It happens in the renal colic, and then what a person will feel? The symptoms of renal colic will be, there will be a flank pain. There will be a flank pain. There will be, sometimes it happens, hematuria, and we call it as, like, then even, there will be vomiting. Like, why vomiting happens? It happens in renal colic. Like, people will ask me why, because of the calcium deposition, why vomiting happens. Like, it's not, it is because of gastric reflex. It happens. Okay, it happens because of gastric reflex. Vomiting happens. So it's like recurrent episodes. First of all, let me tell you, recurrent episodes. Okay, and then we call it as abdominal pain. Like, basically the questions, it will come abdominal pain. They won't mention it so specifically, but you have to understand. Like, I am telling you everything. Like, vomiting happens because of renogastric reflex, and there will be recurrent episodes, and there will be flank pain, but they can mention also as abdominal pain. So always remember that. Then, if like a person must have been suffering from this for, like, suffering since 1 year. Okay, and it's like there will be spasm of gut sphincter. which can lead to constipation. Okay, even it's like constipation happens even after giving laxatives. Like, even if you're giving the person laxatives to treat it, it won't stop. Then you should understand it's renal colic. Like, these all are the symptoms. This. Now we're going to another portion, that is, so I told you about if we give to 11 to 12 mg percent, if it is increased, just imagine it increased a bit more. Okay, there will be high calcium deposition. It will lead, it will lead to the calcinosis cutis. What is it? Or plague, you can say. What is it basically? It is hardening of wall. Okay, it is hardening of wall of blood vessel. Hardening of wall of blood vessels, because this deposition, like, because this deposition of calcium, it will be deposited in the wall of tunica media, which will lead, like, there will be more peripheral resistance. And then if there will be more, I'm sorry about the writing, like, I'm not that good. Just if you don't understand anything, you can let me know in the comment section below. I will let you know there, like, I'll reply you. So what happens if the calcium levels are increased by 12 to 13 mg percent? Calcinosis cutis plague, and what will happen in that hardening of wall of blood vessel? Okay, because it will be deposited, like, a lot of calcium, there will be deposition of calcium in the wall of tunica media in the stomach. So what is this? It is increase in peripheral resistance, which will lead to hypertension. We call it pseudo, okay, pseudo hypertension. Then we we to the secondary Parkinsonism. Parkinsonism. Yeah. So yeah, secondary Parkinsonism. Okay. In this, what happens? Rigidity, bradykinesia, and cases. Basically, it happens we call it as moaning, and groaning episodes. So if there will be more than 13 mg percent, what will happen? There will be systolic arrest. Always remember, there will be hypercalcemia crisis in this case. Oh, it's okay. In no, I mean, this is another topic. Okay, don't. It's like, if there will be increase in 13 mg percent, there will be systolic arrest. Then in hypercalcemia crisis, what happens? Malignancy. Like, there will be squamous cell like cancer of lung. In parathyroid hormone, there will be increase of PTH peptide, and then there will be cancer of breast. Okay, in parathyroid adenoma. Then we come to the other part, that is sarcoidosis. Sarcoidosis, what is it? It is non-caseating granulomas. Okay, so what happens in this case is there will be more synthesis of vitamin D3. There will be increase of vitamin D3, which will obviously, what they will do, they will increase calcium levels and lead to sarcoidosis. Basically, there will be vitamin D3 intoxication in this case. Like, there will be vitamin D3 synthesis will be so increased that it will lead to calcium levels. And then we come to vitamin D3 intoxication. In this, what happens, obviously you got to know, as I told you here, there will be increase of calcium levels. And yeah, let me tell you this. Vitamin D3 intoxication and sarcoidosis, they both can be treated by, even the question comes like that, they will ask you the treatment, and that is steroids. They are treated by steroids, sarcoidosis and vitamin D3 intoxication. Then there is another, milk alkali syndrome. Milk alkali syndrome. It is basically excessive intake. Okay, excessive intake. You can call it antacids abuse or something. Yeah. Then how should we, what should we do if a person got, here we were discussing, just imagine if a person got primary, or he got this, or hypercalcemia, or sarcoidosis, everything. Like I told you, in sarcoidosis and vitamin D3 we can treat by steroids, but let me tell you, in primary, yeah, in primary parathyroid hormone, what will happen? There will be levels, calcium levels will be increased, phosphate level will be decreased, and SAP will be increased, serum alkaline phosphatase will be increased. Always remember this. If question will come, you won't get confused if you remember this. I'll tell you the chart in the end of everything. And so what happens in this case, and then what we have to check, after checking all these levels, we'll do serum PTH assay. If that will be increased, then yeah, it will confirm it. It is also used in chronic stable angina, but we're not studying there, but I just told you, for you should know. So this is the first, this is the second, and the third one is, you can do imaging, like scan. You can take, there will be uptake in, and there is also one TCGG scan, and there is imaging scan named as Systemb. Okay, this is the imaging scan, and this is another scan. We can use that to confirm it. Then we coming to the other section, that is how should we do, in, just imagine hypercalcemic crisis, what should we do? In hypercalcemic crisis. In this case, first thing to do is always remember, they'll ask you what you should do, but if they ask you specifically in the question what you should do first, like the first thing you should do is you should wait a minute. The first thing is normal saline drip for hydration. Always remember. The second thing you will do is, see, hypocalcemic crisis, step by step. Okay. The second thing would be furosemide drip. And furosemide drip, see, so what furosemide, there will be, what we need that calcium levels should get decreased. So it will make loss of calcium through urine. Okay, so it will decrease the calcium levels. But there is two different things. There is furosemide drip, and there is one thing, furosemide bolus. So in what happens in furosemide bolus, there will be excessive diuresis, like excessive, which will make the water loss from the body, and they will elevate the calcium levels. So you should give furosemide drip, because you need calcium to be lost, like it should lose the calcium levels and it should make a decrease. Then what should we do next is, the third is, we should give IV of ibandronate. Always remember this, ibandronate IV. And then the fourth is calcitonin nasal spray. Calcitonin nasal spray. So I told you what should we do. The first is this, third is this. In hypercalcemic crisis, the first thing we should do is normal saline drip for hydration, furosemide drip needed, not furosemide bolus always. Why? Because it will do excessive diuresis, there will be increase in calcium levels and there will be no decrease. And then the third thing we should do is IV ibandronate. Fourth is calcitonin nasal spray. The treatment for this is, we can use, like if there will be a primary increase, we can do surgery, resection of tumor. Okay, surgery, resection of tumor. Then in secondary form of PTH, that is chronic kidney disease. So what will happen? Vitamin D3, okay, PCT, like, okay, let me just tell. So there will be hypocalcemia, an increase of PTH, there will be hypocalcemia. Then there will be increase in PTH, obviously. There will be bone pain in the ribs, bone pain in the ribs, clavicle area, like your bones will pain in the ribs, in the clavicle area, and we call it as exotemic osteodystrophy. Even sometimes it is what happens is there will be osteitis cystica fibrosa. We also call it as brown tumor in pathology. Why we call it the brown tumor? Because it will lead to bleeding, and bleeding will lead to hemosiderin. Okay, so hemosiderin, so it we call it as brown tumor, osteitis cystica fibrosa. What we should do in this, like what how we'll get to know that someone has got this? By, obviously I'm saying hypocalcemia, that means there will be decrease of calcium levels, and if calcium levels are decreased, obviously PO4 will increase, because calcium is inversely proportional to this. Always remember that, don't forget, this is very necessary. Like, it will help you in your exams when you have to answer like very quickly. You can just bring this image and it will come. Then what about, like, there will be low GFR level. Okay, what about the vitamin D3 levels? So vitamin D3 levels will decrease, obviously. Then we'll check serum PTHSA. It's very useful if you do this. It's like it's used very often nowadays. It will show increase. Then we come to the creatinine level. Like, what about serum creatinine levels? That will increase. And then what should we do? Like, the treatment is basically, we should keep hemodialysis we can do, or kidney transplant. It will, like, hemodialysis in 3 weeks, like 3 weeks you can take 4-hour session. It can help. Then we come to tertiary. Okay, tertiary hypoparathyroidism. It is, first of all, untreated. Okay, secondary PTH levels will increase. That's what we call as tertiary hypoparathyroidism, which will lead to it. Like continuous untreated secondary parathyroidism. What happens in this? I'm sorry about the noise. So yeah, what happens in this case is hypoparathyroidism. What is that? Actually, it's a different topic. Wait. Yeah. So hypoparathyroidism. What is this? I will always tell you, if anyone asks you what is hypoparathyroidism, it is autoimmune. It is autoimmune destruction of parathyroid glands. This is like the basic definition. It is, what is hypoparathyroidism? It is autoimmune destruction of parathyroid glands. Then what can we do in this? They will, in this case it is type 1. Okay, then we can do then there is this DiGeorge syndrome. What is DiGeorge syndrome? Basically, in this, thymus and parathyroid. Okay, what happens to them? The thing is, in DiGeorge syndrome, thymus and parathyroid will be underdeveloped. These two will be underdeveloped. And what else happens? Chromosome 22 will be involved. Okay, chromosome 22 will be involved, and rickets like illness will be there. There will be hypoplasia. That's why we call hypoplasia. Then what happens in acute hypocalcemia? So for like DiGeorge syndrome, I told you this hypoparathyroidism, then osteitis cystica fibrosa, chronic kidney, that is secondary. So we are coming to the acute hypocalcemia. That's basically it's tetany. Okay, like there will be post like operative, you can say total thyroidectomy, like we can do. Then there is, we can give a perioral parathysiasis, perilingual. Then we can check the BP curve, that is like SBP. It should be like that. Oh, let me tell you this. So yeah, we should check for what? We should check for Trocio sign. What is Trocio sign? It is median. Let me tell you. Yeah, it is median nerve excitability. What will happen in this? Carpopedal sign, okay? No, carpopedal spasm. It will be like obstetrician hand. That is the Trocio sign. What is Trocio sign? It is the median nerve excitability. Then there is other thing also, Shimotsky. Okay, what will happen in this? You have to tap on the anterior border on parotid gland, and you will see like there will be twitching, like there will be excitability in the facial nerve. So what happens in that? Tap on anterior border on parotid gland, interior like circumoral twitching. It is basically I'm telling you, it's facial nerve excitability. It is this. Then you can also call it like migratory superficial thrombophlebitis. Okay, we can call this. Then the fourth is laryngospasm, stridor, which is death actually. It will be laryngeal edema. The anaphylaxis, it is laryngeal edema. Okay, then we come to the tetanus. Okay, let me write anaphylaxis, laryngeal edema. Then tetanus. What happens in tetanus? There will be technospasm. Technospasm is what? There will be lock jaw, ophistotonus. In this, what happens? How will you like? There will be grinning kind of thing, like rhesus are. Wait, let me write. Rhesus sardonicus. It's grin. So how will we find this? we'll see the calcium is inversely proportional to QT. What is QT? QT, it's basically, we'll see the ECG. Yeah, in ECG you will see QT prolongation will be increased. There will be like QT prolongation will be increased in the ECG of tetanus. Then there will be serum calcium levels that will be decreased. Ionized calcium will be decreased, and serum albumin will be normal.